So, good evening, everybody, and welcome to this Oref Orthopedic online class. For further proceedings, I hand it over to Dr. Johnson. Over to you, sir.
Thanks, Ashok, and welcome everybody. Today, we have Dr. Alaric Arugis from Mumbai, who all of you must be knowing well. He's been the secretary of POSI, that is the Pediatric Orthopedic Society of India, for some years, and now currently is, if I'm not mistaken, the vice president. And he's going to talk to us about the ABCD of Perthes disease, and it's going to be a case-based presentation so that you get a good practical idea how to manage cases that come to you. So over to you, Alaric.
Great, thanks, John, for that nice introduction. And what I've done here is I'll begin by giving you a little overview, because I think going directly to cases becomes a little difficult if we don't have some overview about Perthes, because this is one of the topics I feel which is very confusing, not just for postgraduates, but for even practicing orthopedic surgeons, because it becomes the main element, I think, in Perthes is the decision-making process. And that's where we fumble a lot. So not only from the exam point of view, when you get a particular case in the exam, but even so in practice, once you start as an orthopedic surgeon, when you start getting patients with Perthes disease, how do you actually manage a particular case? Because as we all know, every case of Perthes is different, depends upon the age of the child, the stage at which the child comes to you, and the grade of the involvement of the process. So I'll begin with a couple of caveats right away. And as I said, we'll first have a brief introduction about the way I would approach a case of Perthes disease. And then we'll have a few case examples to cement whatever I've said. The first thing I would like to say is that we must remember that Perthes disease is a condition described, of course, by three different people almost around the same time, around 1910. We know that X-rays came in around 1896 because of William Roentgen. And it's only after that there was a flurry of diseases that were diagnosed because of the availability of X-rays. Remember how, you can imagine how tough it must have been for surgeons at that time to diagnose conditions without the help of an X-ray, but that's what they were doing. And you realize that once X-rays were discovered, it opened up this entire field of orthopedics, because so many conditions which we were unaware of or which we knew clinically, we now had X-rays to prove what was going on in them. So unlike fractures, which could be identified quite easily, even clinically, things like Perthes disease were diagnosed much later. And it's around the same time that these three surgeons, Legg from Boston, Calvé from France, and Perthes from Germany, sort of independently came to this diagnosis of what we now call as Perthes disease. So I think it's acknowledged that it's not a one-man process. In fact, this was actually described by Waldenstrom a year before. But because he didn't recognize this entity, he thought it was TB of the hip. The history does not give him that credit for describing this condition, though he actually was the first to identify it. But we know it now by the names of these three gentlemen. So rather than just calling Perthes disease, it's good to understand that there are three of them: Legg, Calvé, and Perthes. And I've heard a lot of people say calf disease. It's not calf, it's Calvé, which is who's a Frenchman. So what I'm doing today is give you a little overview, as we said, about why there's so much confusion about Perthes disease. Because when we read textbooks or we read various articles, we are sort of exposed to a lot of these different names that come about. People talk about what is Catterall, then there's Herring, there's Reimer, there's Morse, Stulberg, Salter. We talk of head at risk signs. And all of these things make the entire topic of Perthes a very confusing one for people who have not really understood this disease well. I think the first thing to understand about Perthes disease is that it's not a very morbid condition. We must understand that it's a condition which affects children during the growing years of their life. Most of these, in these children, most of this hip conditions will resolve by themselves. We know that from literature that half of these patients will recover and have little disability throughout their lifetime. Even the other half, even if you do nothing for them, will function quite well. and they will have just occasional discomfort through their adulthood and generally become symptomatic around the fifth or sixth decade of life. And it's only the most severely involved patients who will have a very early hip disability in young adulthood. So I think it's important to get this in our perspective that it's not a condition like TB of the hip or a hip dislocation which can cause disability fairly early in life. In fact, that's the reason why it's diagnosed often late. Children usually don't have much symptoms, and even if you sort of miss this condition sometimes, many of these children will progress through adulthood without much problems at all. But now, as people are living longer, that's why you realize that many years ago or many decades ago, it wasn't much of a problem. But as people are living longer now into their 70s and 80s, many of them are now requiring hip replacement surgeries. And that's when people realize that if you really want a good result, it's important to diagnose this condition and treat it well in time. Now, the problem with Perthes is that it suffered from a lack of good natural history. Unlike other conditions, if you read about congenital hip dislocation, you read about clubfoot, a lot is known about the natural history of these conditions because there has been an era in which these have not been treated. So we know that if you don't treat a hip dislocation, if it's unilateral, what happens? If it's bilateral, what happens? Unfortunately, when it came to Perthes disease, almost immediately after it was diagnosed, the treatment began. Treatment began in the form of bed rest, traction, braces, and then later surgeries. So, to find any good study where there's a cohort of children where we have untreated Perthes or where we have not done any form of intervention, because even bed rest is a form of intervention, even traction is a form of intervention. So, to get that sort of a cohort is almost impossible to find, or very, very difficult to find. So, therefore, you'll have very few studies which have long-term results of untreated Perthes. Almost all of them are retrospective. They usually include small number of patients because of poor retrieval of data and absence of controls. And again, we had very few papers that have studied what are the outcomes and what are the outcome measures that we should be using to assess the natural history of this condition. That's the reason why even 100 years after it's been described, we are still struggling to find what is the optimum treatment for Perthes disease. And it's very obvious to understand if you don't have a natural history of a condition, you will not know how any sort of treatment will impact it for the better or for the worse. So some of these few studies that have been there in literature are what I've listed down here. I think one of the good studies came from Iowa, from Stuart Weinstein. And then, of course, some of them from Scandinavia, where we know that Scandinavians have a very good registry of various conditions. If you want to pick up long-term survivals of total hips, of tumor prosthesis, of so many conditions, always go to the Scandinavian population because they have a very stable population. They have an excellent healthcare system. They document almost every patient and record them quite clear, quite easily. And very few Scandinavians move out of their home country because they have such a good way of life there. So as we have seen from these few studies that are available, I think this is important to get into our perspective that between the ages of 20 to 40, 70 to 90% of patients are active and pain-free, reiterating the concept again that Perthes by itself is not such a bad condition. In fact, many of them are asymptomatic. They don't present to the orthopedic surgeon. They are usually diagnosed in adulthood when they come with hip pain. And generally, it is the adult orthopedists rather than the pediatric orthopedists who experience these patients for the first time. Also, we know from some of these few natural history studies that despite very bad looking x-rays sometimes, these patients have good range of motion. And that's the clinical paradox. So it's important to understand that we should not be treating x-rays, but rather treat the physical findings or the clinical picture that the patient comes with. Because despite sometimes look very bizarre looking x-rays and very severe amount of damage, the clinical picture is not so bad. But we know that by an average age of 50, about half of these patients will have disabling pain and osteoarthritis requiring a total joint replacement. And as you live longer, for untreated Perthes, by the sixth or seventh decade, majority will have evidence of degenerative joint disease. So these are few studies which have really shown this well to understand on one end of the spectrum that it's not a very bad condition. It does not cause very severe morbidity, but in today's day and age, when people live much longer into their 70s and 80s, it does become an important condition to prevent long-term disability. Now, the important thing is when we look at Perthes disease, for some reason, a lot of orthopedic surgeons feel that the treatment of Perthes disease is containment. And I would first like to take this away from uh, your minds that when we speak of Perthes disease, the treatment is not just containment. In fact, when we look at patients who come to us with various stages of the disease, I think containment works in just about half of these patients. There are so many other things that we need to do when patients come to us with clinical symptoms of hip pain. And remember, they're not come to you for the diagnosis of Perthes. They're not come to you because they know they have Perthes. They come to you because they have pain in the hips, which is usually mechanical in nature, which usually occurs at the end of the day because of running, playing, and being active. So the first thing that is required when you have a patient with hip pain is to treat the hip symptoms and not to treat the X-rays. And I'll keep reiterating this throughout this talk that the central theme of treatment of Perthes is to treat clinical symptoms and not to treat the X-rays because we can go really wrong if you start managing X-rays. So the first thing if they have hip pain is to relieve the pain, and we know the best way to do that is by putting the child in bed, taking rest for a few days. Remember, the rest that we're talking of here is not for 3 months and 6 months, but for a period of a maximum of 10 to 14 days. And that's mainly to allow that hip synovitis and the stretch on the capsule to resolve. So it does not mean what we used to do 20, 30 or 40 years ago, where children were kept in prolonged traction for 3 to 4 months. That is completely outdated because you know that can cause a lot of problems like osteoporosis even in young children. It can cause muscle abnormalities. It can cause atrophy of muscles and it can cause more harm than good. So bed rest for a period of anything between 10 to 14 days, maximum of 3 weeks. Supplement them with a week or 10 days of non-steroidal anti-inflammatories to reduce the pain. Give them traction again for two reasons. One is to relieve the pain, and second is to restrict them in bed. Remember, traction does nothing else except to relieve pain and to keep the child in bed so as to get a more compliant child. Once you have a relief of pain and traction, the next is to restore range of motion because the key really in Perthes disease is to keep the hips moving. To avoid weight bearing, which is bad for the hip because weight bearing we know can deform the head, especially in the phase when the head is soft. But range of motion is always good because range of motion will allow the head to remain round during the phase of collapse and fragmentation. Institute physical therapy, which basically works on improving function. And the main goal of treatment in the long term is to minimize femoral head deformity at the completion of healing. So this is the long-term goal of Perthes. So the short-term goals are relief of pain, traction, range of motion, improve function. And the long-term goal is to minimize that femoral head deformity at the completion of healing. I think one of the best classifications that we have about the prognosis of Perthes is this one which has come from Stulberg. And though this was published almost 40 years ago, it is still valid even today. And I think all of us must be aware of this classification. Out of all the myriad classifications that you'll hear of in Perthes, this is one classification which is worthwhile to understand because it defines your long-term prognosis. And what Stulberg showed is that if you have a normal looking head which is round with what we call a spheric congruency, that hip is likely to last a lifetime. So that's what's called a class 1 result of the Stulberg and Cooperman classification. If the head is still round, but there's slight amount of broadening of the head and a little amount of shortening of the neck, what's called coxa magna and coxa breva, the head is still spherical. This is still compatible with a good result, and most of these patients will not be symptomatic. Most of them will do well even in the long term. So if you get a Stulberg class 1 and 2 at the end of skeletal maturity, because remember that this classification is at skeletal maturity. I've frequently seen postgraduates present a case of a 10-year-old child and saying, this is Stulberg class 1 or class 3 or class 5, and that's wrong. Because the Stulberg classification can only be applied once a child is skeletally mature. And that generally means when there's closure of the triradiate cartilage. So don't use the Stulberg class. For all these different classifications of Perthes, you must know when to apply them. And the Stulberg classification is valid only in a skeletally mature patient. All right, and that's important because it prognosticates. If you have a Stulberg 3 or a 4, 3 is what is called, and 4 are basically what we call aspheric congruency, which means that the femoral head and the acetabulum are congruent, but they are aspheric. And that's an important terminology that Stulberg and Cooperman came out with, saying even if you have an aspheric head, as long as it's congruent with the acetabulum concurrently, that femoral head, that joint can still last for some time. It may not last till you're 70 or 80, but it will last you at least till your middle age. So if you land up with a Stulberg 3 or a 4, where you have an ovoid mushroom-shaped head, or even a flat head, but with a flattened acetabulum congruent with it, then that's what's called an aspheric congruency, and that will still last you for till the ages of 30, 40, or sometimes even 50 years of age. And it's only a Stulberg 5 where we have what's called an aspheric incongruency, where you have a flattened, deformed head with a normal looking acetabulum, which in fact will give you symptoms very early in adulthood. And by your 20s or 30s, you will need a joint replacement. So I think this classification is an important one to remember. It can only be used at the completion of skeletal maturity, as we have said, and classify them into three types: spheric congruency, aspheric congruency, and aspheric incongruency. So if you look at these 5 X-rays, in all of them, there's Perthes disease of the right hip. And that's a Stulberg 1, where you have a completely normal looking hip. You have a type 2, where you have a slight coxa magna and a coxa breva. So this means that there was avascular necrosis, but not so severe. It arrested in time, and you didn't have a very bad result. This type 1 and class 2 are ones which will last a lifetime. Here you have a Stulberg 3, where you have a mushroom-shaped or an ovoid head, as you can see, but it's still congruous with the acetabulum, though the acetabulum is falling short and it's only covering half of the femoral head. This hip usually will not become symptomatic before the ages of 30 or 40 years of age. Then you have a Stulberg 4, where you can see the sagging rope sign, where you can see that the head is fairly deformed, it's flattened, but at the same time, it is still congruous with the acetabulum. And the acetabulum has also become capacious to accommodate that very large head. And this hip also may last you easily up to your 30s. So don't be too eager to operate hips like this unless they are very symptomatic. And it's only this class 5 where you have severe destruction of the femoral head, where you have a deformed head with a normal acetabulum, where you are likely to require hip replacement in your adolescence or early adulthood. So what we know is that if you want to achieve a good long-term result, you must try and achieve a Stulberg class 1 or 2 by the end of skeletal maturity. And therefore, all our treatments that we provide for Perthes are in order to try to achieve these 2 types of X-rays, not this, and definitely not this. So that's the difficult thing in Perthes disease, because we are very good as orthopedic surgeons in treating what's in front of us. If I have a fracture acetabulum, as John says, I know how to treat that. If I have an ankle fracture, I know how to treat that. If I have a hip dislocation, which is in front of me, I know how to treat it. But in Perthes disease, what we're called upon as orthopedic surgeons is to almost be like astrologers who have to look into that crystal ball and try and see that a 7-year-old child who's come to me with very minimum hip symptoms, who has an X-ray which looks in a particular form, how do I ensure that that hip X-ray and that child at 7 years of age, that I can do something to that child to allow him to have a Stulberg class 1 or class 2 at the end of skeletal maturity. And that's why it's difficult sometimes to come to a decision making in Perthes, because we have to look at various prognostic factors which impact the final outcome in Perthes. And some of those prognostic factors are what I've listed down here. So if you're aware of these 5 factors and you put them all together, this would help you in your decision making process. Because over the last 100 years of Perthes, what we have realized is that the final outcome at skeletal maturity, to allow us to achieve that Stulberg class 1 and 2 at skeletal maturity, depends basically on just a combination and permutation of these 5 factors, namely the age of the child, the range of the hip motion, the stage at which the child has come to you, what is called the evolution of the disease, and what we now classify using the modified Elizabethan classification. The grade of epiphyseal involvement basically means what is the extent of the head which is involved. And lastly, the amount of collapse or extrusion that has happened in the femoral head. So if you combine these 5 parameters and you put them all together, that's when you'll be able to prognosticate the final outcome of Perthes disease. So I'll talk about them a little more in detail, because these are the 5 important factors that help us to come to a decision-making process. So let's look at the age of the child. The age of the child is something which is obviously not in our control. That's the time when the child presents to us with hip symptoms. And what we have found from our understanding of 100 years of Perthes disease is that children who are less than 6 who come with a diagnosis of Perthes generally tend to have a good outcome. Even if the x-rays don't look so good, even if they start showing a bit of extrusion, they still tend to do well because age is on their side. And we know that Perthes is a long-standing process. It takes about 3 to 4 years to resolve completely. And because the child has more years for skeletal maturity, therefore there's a higher chance of the child's hip remodeling well. Between the ages of 6 to 9, when most of our patients present to us, the prognosis is mixed. If you have lesser involvement of the femoral head, the outcomes are generally better. If you have more involvement, you have a worse outcome. And over the age of 9 or 10 years, when you have basically very little time for skeletal maturity, especially in a girl who hits skeletal maturity by the age of 12, you know that the Perthes at that age is likely not to have a good outcome because of the fact that there's very little time for skeletal maturity. The second important thing is the range of motion. We know that if you want to obtain a spherical head at skeletal maturity, the key factor is the hip range of motion. If you can ensure that the hip is moving well with a good amount of abduction, internal rotation, then those hips are the ones who remain spherical and who will have a good long-term outcome. So therefore, maintaining hip range of motion is crucial. And conversely, if you find any patient during your follow-up is losing hip range of motion, that's a red flag to tell you that this child may not have such a good outcome because it is directly related to the shape of the femoral head that is evolving as the disease progresses. The third important thing is the stage of the disease that the patient comes to you in. And this is what we use the Elizabethtown classification. So this is basically the evolution of the disease. It keeps changing as the hip progresses through Perthes. This is basically a modification of the Waldenstrom stages, and it has been described as the Elizabethtown classification. And Benjamin Joseph from Manipal, who is a professor for many of us and teacher to many of us as orthopedic surgeons, modified that, revised the stages even further. And I think you must read this article, which is a masterly one in JPO 2003. So what are these different stages? Remember that Perthes goes through 4 different stages, starting from the stage of avascularity, which is the first stage, the second being the stage of fragmentation, the third is the stage of revascularization, and the final is being the heel stage. So what is further divide the stages into 2 parts. And I think all of us should be aware of it because when such a case presents to us in our clinics or comes to us in the exam, we must be able to classify the stage of the disease based upon this Elizabethtown classification. So very simply, stage 1A is a very early stage of Perthes where the epiphysis is avascular. All that it appears is that it's denser compared to the opposite side because when bone dies, it does not take part in the remodeling process. There's lack of blood supply, and therefore a dead head is always avascular. But there is no loss of epiphysis. If you measure with the opposite side, the height of the epiphysis is exactly the same as the opposite side. Once it starts losing some height, it has now entered stage 1B. So stage 1 basically is a stage of avascularity where the head is dense. 1A, where the height of the epiphysis is normal as compared to the opposite side. 1B, where there's loss of height in addition to the sclerosis. Then the next stage is the fragmentation stage. We know that this is the crucial stage of Perthes disease, that once it goes beyond the avascular stage, and as new blood vessels start forming within the epiphysis, remember that avascular bone is hard bone. It does not collapse. The chance of collapse happens in the stage 2, what's called the stage of fragmentation. And what does this basically mean? Is that as new blood supply enters and starts reossifying that avascular bone or revascularizing that avascular bone, that's when the epiphysis is soft, maybe not so much in the physical sense, but definitely in the biomechanical sense, and therefore starts fragmenting. If you see a single vertical fissure, 1 or 2 fissures, then that's early fragmentation, and that's called stage 2A. Whereas when you see multiple fragments and you have more than 2 vertical fissures, then that's advanced fragmentation, and that's stage 2B. This important line here between stage 2A and 2B is the crucial watershed zone, as we see later. That if you pick a patient and you start treating that patient before stage 2A, you can impact the natural history of the disease. Once that child goes into advanced fragmentation, where the head is already revascularizing and fragmenting in a very extensive fashion, you are not much able to change the natural history of the disease. So it's crucial to pick up patients, as Benjamin Joseph has shown, before the stage of advanced fragmentation. That means in stages 1A, 1B, or 2A. Then we go on to stage 3, which is the reossification stage. And this is a stage where really whatever you do is not going to change your natural history. This is just a progression of Perthes disease. It's divided again into 3A and 3B. 3A is when you start seeing little immature woven bone which is forming at the periphery of the epiphysis. And once you see a more mature lamellar bone, which occupies at least 1/3 of the circumference, and that's stage 3B. So basically, it's just a further evolution of the stage of reossification. And finally, you have that last stage, which is stage 4, where the entire reossification and revascularization is complete. There's no evidence of any avascular bone either, and that's the heel stage. So very simply, you have these 4 stages divided further into 2 subgroups each. So you have the avascular stage, the fragmentation, or the stage of maximal epiphyseal resorption, the stage of revascularization, the stage of healing, and finally the completely healed stage. So you have these 4 different discrete stages that Perthes evolves through. And then we come to this next concept, which is called grading. And remember that stage and grades are completely different things. The stage of a disease is an evolving process. Over the span of 2 or 3 years that Perthes runs its course, it will keep changing. The patient will definitely keep evolving from stage 1A until stage 4. Whereas the grade of the disease basically indicates the extent of the involvement, and that's something which ideally should not change at all. And here, we have 2 or 3 different classifications. The one that is stood the test of time is the Catterall grade. And very simply, it's divided into 4 grades. But what is important is grade 1 and 2 versus grade 3 and 4. So 1 and 2 is where you have less than half of the head involved. Grade 3 and 4 is where you have more than half of the head involved. That's what's really important. Trying to split hairs between Catterall 1 and Catterall 2, or between Catterall 3 and Catterall 4 is not so important. What is more important is to say less than half of the head involved, more than half of the head involved. Because what has been shown very clearly, that when you have more than half of the epiphysis involved, that epiphysis is now susceptible to further collapse and extrusion. So the grade of the disease is another prognostic indicator. When you have more than half of the head involved, then we know that that head is liable to have extrusion. And finally, we have this last classification, the last prognostic factor, which was described by Herring, where you talk of the extent of collapse. And what Herring showed is that if you divide the epiphysis into 3 parts on the AP X-ray, the lateral 1/3, the middle half, the middle 1/3, and the medial 1/3. And what he showed is that if the lateral 1/3 is involved and if it starts collapsing, then that head is going to extrude over time. So it is this lateral pillar which is responsible for the integrity of the femoral epiphysis. It's not so important what's happening in the middle or the medial epiphysis. But once you have the lateral part of the epiphysis or the lateral third collapsing, that is when you know that this head is at risk for extrusion and secondary osteoarthritis. So that's divided into heading A, B, and C. And then, of course, you have also a subgroup which is called BC. So heading A is when you have a normal height of the lateral pillar. B is where less than half of the lateral pillar is collapsed. And C is where more than half of the lateral pillar is collapsed. So therefore, once you have these 5 important parameters which help you to come to a decision-making process, this will really help us then to consider which hips will benefit from containment, which hips will not benefit from containment, and which hips do not require containment. And since the last 20 years or so, there's a group which has been formed called the International Perthes Study Group. And Manipal is one of the centers from India, which is contributing to this International Perthes Study Group. And they've come out with various papers during the last 20 years collaboration. The first one that came out in 2004. And if you put all these 5 factors together, this is how we can come to a decision-making process. So generally, you see that if you have a younger child who's less than 6, as we already said, most of these children do not extrude. Most of them do well, and therefore you can afford to be conservative with them, as we'll see in some of the case examples later on. Between the ages of 6 to 9 or 6 to 10, and sometimes you can take it up to 12, but usually we talk of 6 to 9 or 6 to 10. These are the patients in whom, if you catch them early in stages 1A, 1B, and 2A, and you treat them in the correct fashion, then you can ultimately result in a spherical femoral head and result in a Stulberg type 2, class 2 or class 1. Whereas in the older child, once they cross the age of 10 years, generally we should not consider containment, because whatever you do, they still will land up with a bad result. And then the parents will blame you, saying that your surgery or your intervention caused them to have a bad result. Looking at the extent of physical involvement, if you have less than epiphysis, half the epiphysis involved, that is catarrhal 1 or 2, again, there's no need to consider containment, because these hips will anyhow do well by the natural history. Once you have more than half the head involved, that's a catarrhal 3 or 4, if the other factors are also present, then you may consider containment for these patients. The next crucial phase, decision-making process, as we said, one of the most important ones is the stage of the disease. And I've already said to you this before. This is where the landmark work from Benjamin Joseph from the work in Manipal, that if you cross stage 2A, that means you go into stage 2B, 3, and 4, these are children you should not contain at all, because you have basically missed the bus. Whatever you do at a later stage, the result is never going to be good. And this landmark paper, as we said, from JPU 2003, Benjamin showed very clearly that if you do containment surgery early in the stage of the disease, before it has undergone extensive fragmentation, then the chance of developing a spherical femoral head is 16 times higher. That's an important thing to remember. If the odds ratio 16 times higher if you do it in the early stages than if you wait for advanced fragmentation. Okay. He's also shown that if you do containment early by a varus femoral osteotomy, you may even be able to alter the natural history of Perthes disease. And Benjamin Joseph has again shown that if you do them in the avascular stage, almost prophylactically, you will find that some of these hips may bypass or even reduce the duration of fragmentation. So this is an important finding that he has shown, that if you do them early enough, the patient may completely bypass the fragmentation stage and go straight towards into healing. Or if they don't bypass it, at least the duration of fragmentation stage, which generally is around 12 to 18 months, may be curtailed to 6 months or less. So basically, you're causing the disease to heal faster by doing a containment surgery. And this again reinforces the concept of how important it is to do early stage surgery, provided the other parameters are met. Finally, if you consider the hip range of motion, if you have a stiff hip, you should not be doing containment surgery. And I frequently have, when I attend various conferences, some of my colleagues and younger friends coming up to me with an X-ray of a patient with Perthes disease saying, this is the patient's X-ray, what do I do? And I never give an opinion, because it's impossible to treat Perthes on the basis of an X-ray. Because then I then ask them, what's the age of the child? I'm not sure, maybe 6, maybe 8, maybe 10. It's very different, because each of those ages are going to have a different prognosis. When I ask them what's the range of the child's movement, they don't know that. So remember that the treatment of Perthes is not based on any one parameter. And you just cannot use the X-ray to come to a treatment decision that based on this X-ray, this is the treatment that's required. Because as I've shown you, all those parameters, the 5 parameters, have to be considered together before you come to a proper decision in Perthes disease. So I put it together in a chart, and I think this makes it really easy to understand that if you look at those 5 prognostic indicators, the age, the stage, the grade, the range of hip motion, and the extrusion, that helps to make a decision-making process. And as you can see, if you have green color, then that's a green signal to go ahead with your containment surgery. But the minute you have it in the red signal or the red traffic light, you know that you should halt and not consider these patients for containment surgery. So that's an important, again, message I'd like to give for this talk, is that every patient, the treatment of Perthes disease is not containment. In fact, only I would say half the patients who come to you are candidates for containment. The remaining of them either do not need containment, they are too late for containment, or containment will not change the natural history of this condition. So you must be very discerning when you consider surgery for Perthes disease, and Perthes does not equal containment. So here's a hip which is actually crying for containment. All right. What are the parameters that are satisfied here? This is a child who's between 6 to 9 years of age. It's in that early stage of avascularity. As you can see, that there's probably a stage 1B where you have sclerosis, where you can see there's some collapse of the femoral head. Here you can see that the head involvement is more than 50%, and the lateral pillar height is reduced to 50% or more. So this is a heading B, which is likely to extrude. So because of all these parameters, really have a role to play. So I think some of you still remember, I don't know whether this is still available, the 50-50 biscuit, but I think it serves a very good analogy for Perthes disease, that if you consider, the age between 0 to 12 years, if you say less than 6, you generally don't do surgery. So more than 6, you tend to do surgeries. If the range of motion is more than 50% of abduction internal rotation, you can go ahead with the containment surgery. If the extent of involvement is more than 50%, you should consider surgery. If the lateral pillar collapse is a heading B or a C, you should consider surgery. So basically, the 50-50 rule tends to work well for Perthes disease, that only when it fulfills all of these parameters that child is a candidate for a containment surgery. So having said that, let's look at a few examples, because I think it's so difficult unless we put cases together, that only when we see each individual case, and as I said, working on all those 5 decision-making parameters, the age, the stage, the range, the grade of involvement, and the severity of collapse, that you can come to a decision-making process. So here's a 4-year-old boy with left hip pain and limp. He has a full hip range of motion. And as you can see, there is some collapse. There's no collapse, sorry, but there is some sclerosis of the left hip epiphysis. And that's what's called the stage 1A. So if you see that this child is young in age, the range of motion is almost full, the stage of the disease is early, and he has about 50% or so involvement, he's likely to develop a good result. And therefore, we elected to leave this child alone. Whenever the child had pain, put the child in bed rest for some time, apply traction for a period of a week, give some NSAIDs, allow the child to range the hip out, avoid activities like jumping, running, or sports that are likely to cause further collapse of the head, but allow weight bearing to occur. Institute range of motion exercises to keep the hip mobile. And you can see the gradual evolution of this disease process. This is now to stage 1B. This is stage 2A. And as I've said, the x-rays sometimes can start looking scary. And many people at this stage will start saying, oh my gosh, this is likely to extrude. But remember, this is still a 5-year-old child. He's younger. He's got a lot of growth remaining. The range of motion is still quite good. So despite these x-rays which don't look so nice, we still decided to understand our decision-making process and not do anything for this child. And then you can see it looks even worse. This is now May 2008. March 2008, a whole year after the symptoms, but the child had no pain. The child had a full range of motion. The x-ray looking really bizarre. I remember he took opinions from about 4 or 5 different surgeons, many of whom recommended containment surgery. We decided not to do that. This is now December 2008. You can see it now progressed to stage 3A. There's much more extensive involvement with now healing, which is occurring. This is now February 2010. 3 years after the disease process. So you can see how long the process is lasting. This is 2010. This is where the child is 9 years of age. And I can tell you that this child ultimately will result in a Stulberg 1 or a Stulberg 2. So though those x-rays look terrible over the years or over the months as you're progressing, because you knew about your decision-making process, that the age was in the child's favor, the range of hip motion was remaining good, the child had no symptoms, the child was doing well, all we're seeing on the x-rays is the natural history of Perthes disease, that is gradual progression from from avascularity to fragmentation to collapse to healing. But because the range was good and the age was young, we decided to be conservative and avoided an unnecessary surgery in this child. So you must be extremely discerning, because sometimes you can have pressure from parents who take consultations from other people who say, this child should have been operated long ago. But actually, if you are clear about your decision-making process, you would realize that this child does not need unnecessary surgery. At the same time, I would caution you all that this should be a dynamic process. It's variable. It's dependent upon a number of variable factors. If any time during this process, the child was starting to lose range or the child was starting to extrude in a large way, I would reverse my decision and go ahead with the containment surgery. So remember, we must be flexible and fluid with our decision-making process. Just because when the child was 4 years of age, we decided to be conservative, but under our vision, the child is deteriorating, not on the x-ray, but clinically, we should change our decision-making process and be flexible in our approach. So that's why regular follow-ups are important. I often have people ask me how often should we take X-rays, and remember that we don't need frequent X-rays in these children. You can see that Perthes is a long drawn process. This natural history itself has shown you it's taken almost 5 years from the age of 4 till the age of 9 for the disease to heal itself completely. And it's still not completely healed. It still has some amount of healing left to go. But too many X-rays are generally not required. What we say is that during the phase of avascularity and fragmentation, when you know that the hip is at highest risk for collapse, you should take X-rays every 4 monthly. That is more than sufficient. And as the hip starts going into the healing phase, you can increase that frequency to twice a year and later on even to once a year. So in the crucial phases, when the hip has a chance to fragment and the hip has a chance to extrude, take X-rays more frequently, but not more frequently than 3 to 4 monthly. And later on, you can decrease that frequency to twice and then even once a year, because too many X-rays in these children are not required. Now, on the other hand, let's come to a second case example. Here's a 7-year-old boy who has hip pain and limp. He's got restriction of hip range of motion, of abduction and internal rotation. This is stage 1B, and this is a heading C. So you can see that this hip, all factors seem not to be in a good position. The child is older. There's restriction of range of motion. It's an advanced grade of involvement. That's more than 50% of the head which is involved. But it's an early stage still. It's still in stage 1B. So the first process is not again to do containment. You can see that this child is a little stiff. So the first thing is to give bed rest, to give traction, to allow the hip range of motion to improve. We're not treating the X-ray, but we're treating the child clinical symptoms. And only when the range of motion improves that we should go ahead and do a containment surgery. And that's what was done. This is 1 year post-op. This is 2 years post-op. And you can see what we have done, that when we have done the osteotomy, we have done it fairly high up, and we have put a plate which has a screw going through the greater trochanter. And that's the other thing that Benjamin Joseph talks about, because we know that over time, the trochanteric overgrowth can tend to occur. Remember that Perthes disease is a disease of the femoral epiphysis. And if you don't treat the trochanteric epiphysis, then that tend to overgrow because there's decreased growth in the proximal femur. And you can land up, even if you have a spherical head, you can land up with a coxa vara, you can land up with a functional shortening because you have not addressed the trochanter. So always drill the trochanter and put a screw across it. Here's another few examples. I won't go into more details, but that's again showing you the decision-making process. 8-year-old boy, stage 2A of the disease. Before you have advanced fragmentation, we know that if you leave this alone, the child is going to collapse. Here, we have not put a screw, but we have drilled the trochanter, which is also okay. But despite that, if you have not put a screw across it, you can end up with trochanteric overgrowth. And as you can see here, this child has decreased articular trochanteric distance. And though the head will be round and though the head will land up with a Stulberg 2 at best, he will still have a bit of a limp because we didn't address the greater trochanter sufficiently by putting a screw across the trochanter. Here are some more examples. Again, as you can see, open wedge osteotomy because they heal really well. Don't overdo the varus. That's extremely important. Most of these children will need about 15 to 20 degrees of varus. Another thing I've seen is that people tend to overdo the amount of varus. Anything more than 20 degrees can cause the child to have excessive coxa vara with a subsequent very bad limp because of a negative articular trochanteric distance. So you must be careful not to decrease the neck shaft angle to less than 120 or 125 degrees, and don't do more than 15 to 20 degrees of varus at the osteotomy site. Again, as you've seen, fuse the trochanter, and this child will land up with a good result again. Another different type of implant over the last few years, we know that we now have the proximal femoral LCP, which is available to us. This is a very useful implant because it helps you to fix the plate really well. These children do not need any external support in the form of a plaster spica. They can be mobilized right away. And we started using this implant now more for our femoral osteotomies. That's a proximal femoral LCP. Here, of course, you can't get a screw to the trochanter. So even more reason for you to drill the trochanter. And sometimes you can put a small screw just across the lateral trochanteric apophysis to arrest the trochanteric growth. And finally, here's an 8-year-old girl. So again, you can see an older age. You can see that there is a stage 2A, that's a cateral 4 with a heading C. So again, we know that there's already some extrusion happening here. If you leave this child alone, she's going to end up with a poor prognosis. So therefore, we underwent again the same procedure of doing a varus osteotomy. and that's a 2-year follow-up, and that's a longer follow-up at 16 years. That's 8 years post-op, and you can see that that's absolutely a round head. This is not a Stulberg 1, but it's rather Stulberg 2, where you have a coxa magna, you have some shortening of the femoral neck, but because it's a Stulberg 2, if you compare, if you had left this hip alone, this child would have done extremely poorly, because this hip would have extruded all the way out and ended up with a very bad result. But because we intervened at the right time, this hip has a perfectly good result and will land up with a good picture. So in conclusion, what I would say is that don't always assume that the treatment of Perthes disease is containment surgery. Over the last 100 years or so, since we've understood Perthes disease, a lot of light has shone upon our understanding of Perthes disease. We know that younger the child, the better the prognosis. The older the child, the worse the prognosis. So we tend to be a little more aggressive in the older child rather than in the younger one. We know that boys do better than girls, and the simple reason is that boys have a little more time for healing as compared to girls. And we know that if you end up with a round head at skeletal maturity, you have a much better result than if you have a mushroom-shaped head at skeletal maturity. So there are a few of the things that we have learned about Perthes disease over the last many decades of its evolution. So if there are any questions, we'll take them now. And thank you so much for your attention.
Thanks, Alaric. Can you stop sharing your screen, and then you've done that? There's Alaric's video.
Yeah, let me just...
Any questions from the delegates, the DNB students, etc.?
Hello, sir. Good evening.
Yeah.
Yes.
Sir, am I audible to you?
Yes, go ahead.
Yeah, you're audible.
Yeah, sir. The surgery which has been described for containment is a varus subtrochanteric derotation osteotomy. So, what is this derotation part? What do we derotate? And the second question.
A misconception. Again, I would stop there, right, by saying that there's no derotation. So we should not be talking of the word VDRO. Therefore, it's an outdated word to use VDRO. The word that's used here, the femoral varus, so it's called it FVO, is the right term to use. It's a femoral varus osteotomy. In fact, what you need to do is not rotation, but what you need to give is, in fact, extension of the fragment. Because you're trying to cover the anterolateral fragment, and derotation won't do that. So the varus is covering the superior fragment. The extension is covering that anterior fragment. So really, it should be a varus extension osteotomy. But even if you just do varus, that's more than sufficient. So we should get out of using that word VDRO, because that's a completely wrong word to use. It's a femoral varus osteotomy, and if you just give that 15 or 20 degrees of varus, that should be sufficient. Okay.
Yes, sir. Sir, the second question, what about hinged abduction that we talk about, sir?
Yeah, so I've not covered that in this talk, because this is a very basic talk just of Perthes, which is most likely to come in your exam. Now, as we have said, there are two types of hips which will come to you in your exam and which you deal with in practice. One is what we call these containable hips, which fulfill all these 5 criteria that I've enumerated, those 5 prognostic indicators of age, stage of the disease, range of hip motion, grade of the disease, and the extent of extrusion. But there's a separate category which are called non-containable hips. That means either they have come to you too late in the process, or where the head is so much deformed that containment will make them in fact worse than what they were before. So the minute you see a non-containable hip, and one is what we call a hinged abduction, where the epiphysis is extruded to such an extent that when you abduct the hip, rather than the epiphysis going inside the acetabulum, it hinges on the lateral aspect of the acetabulum. And again, to make it a little more complicated, there are 2 types of this hinged abduction. One is what's called a reducible hip hinged abduction. That means if you do something, you can actually reduce them within the joint. And that something usually means a medial soft tissue release. So a lot of these, because they have hinged abduction for a long time, tend to get an adduction contracture. And if you release the internal structure, that's the medial adductors, along sometimes with a medial capsule, you can actually reduce some of these hinges. So there's what's called a reducible hinged abduction, and some which you call an irreducible hinge abduction. So if you have a reducible hinge abduction, That's another way where you can do a medial soft tissue release and try to contain them just by a soft tissue procedure, not trying to do a bony procedure. And then if you want to contain them further, rather than doing a femoral procedure, do something on the acetabulum, because generally these heads are large. And if you do varus, it doesn't help much, but rather by doing a shelf to the acetabulum and adding more bone over the femoral head helps. So these reducible hinged abductors, what you can do is a medial soft tissue release, get the head in, and then add a shelf to the acetabulum to extend the acetabulum over that large head. If you have a non-reducible hinged abduction, that means the hinge is so bad that it refuses to reduce within the acetabulum, then those are patients in whom a valgus osteotomy sometimes helps. That means you actually take the hinged part away from the lateral edge of the acetabulum and allow it to be outside so that it does not impinge upon the head. So that's a different treatment process altogether, and I've not covered that in this talk because that's an entirely different ball game when you deal with a non-containable hip. Nowadays, we know that hips which are non-containable because you have missed it in the early stages. The hip has come to you at a later stage now. They're non-containable. We know that if you leave these hips alone, over time they will develop what's called femoroacetabular impingement. And nowadays you have much newer surgery which have come about when we have understood femoroacetabular impingement, because we know that over time these large heads tend to cause labral injury and early osteoarthritis. So now we have, because of understanding the femoral head vasculature, we have surgeries called as surgical dislocation of the hip, osteochondroplasty, where you actually trim that extruded part, which is just a fancy name for that colectomy that we used to talk about many decades ago. So many decades ago, a surgery called colectomy was described. And basically, an osteochondroplasty is just that. You surgically dislocate the head. You remember the blood supply which comes in from the lateral epiphyseal vessels. You don't damage that at all. And then you do a colectomy or an osteochondroplasty of the overhanging head so as to remove the impingement that the femoral head or has on the acetabulum. So these are different procedures that we tend to do for the non-containable hips, which are hips which have come to you late, which should not be contained or cannot be contained. Then either you do a valgus osteotomy, a shelf procedure, a Chiari osteotomy, surgical hip dislocation and osteochondroplasty, or what's even more recent, which has come about, is what's called femoral head reduction surgery, where you actually remove the central part of the deformed head and bring the two edges together. And that's something that only an expert hip surgeon who has a lot of experience with surgical dislocation, understands the vascularity of the hip, should be undertaking. But that's one of the recent advances in hip surgery, which is called head reduction surgery, which is a form of salvage or a form of hip reconstruction.
So, few terms for the beginners, like you told about containment, congruency, extrusion. These terms, because in the beginning it's difficult to understand. So please explain it.
Sure. So basically, these are radiological terms. Okay, because clinically, all that you can make out is the child losing range. So clinically, if you see a child who's developing pain and is losing range of motion, that's an important red flag, because the range of motion indicates the shape of the head. The minute you start losing range, of course, one could be because of pain and synovitis, but that's a transitory thing which happens in the early stage of the disease when you have a subchondral fracture. But as this disease progresses and evolves, loss of range of motion is an important red flag to tell you that the head of the femur is getting abnormal in shape. So if you take an X-ray and if you draw those lines that we're all aware of, you know that the horizontal line, which is along the tridentine cartilage, is called the Hilgenreiner's line, and you draw one vertical line, which is on the lateral border of the acetabulum, which is called the Perkins line. And these are the two important lines that we use in the hip joint. And if you find that any part of the epiphysis start lying outside the Perkins line, that's called an extrusion. So normally we know that the head is a sphere, the acetabulum is a hemisphere. So it's never that the entire femoral head, even the normal X-ray, is ever fully contained. Normally about 10% of the head lies outside the confines of the Perkins line. That's the normal hip X-ray. But if you find anything more than 15% of the head lying outside the Perkins line, then that's called extrusion. And the other way to make out extrusion is that if you see the Shenton's line broken, that shows you that the head is gradually subluxating out. So what are the signs of extrusion? You'll find that the Shenton's line is broken. You'll find that the medial joint space is widened. You'll find that the epiphysis is starting to lie beyond the Perkins line by more than 15%. So these are all radiological signs that this hip has started to come out. And the reason why it's extruding is because it has lost the support, the lateral pillar that Herring talked about. And this hip is at risk for developing further subluxation, further extrusion, and further damage. So before this extrusion is occurring, or in the early stage of that extrusion, in stages 2A, before it starts fragmenting extensively, is when containment has a role to play.
So, Alaric, what about arthrograms and MRIs? Do they have a role in your practice, or you've stopped doing these?
Well, certainly. So, arthrograms are a very good method, especially when you're not sure. And I'll tell you where arthrograms are generally useful. They're useful when you have a younger child, because we know that a lot of the epiphysis is unossified in the younger child. So, if you have a child who's 6, 8 or so, and you really want to understand the full extent of the head, because we know that only some part of the head is ossified in the younger child, then arthrograms are useful so that they delineate the whole epiphysis to us really nicely. They're very useful for hinged abduction. So clinically, if you're suspecting hinged abduction, then arthrograms are very useful because it's a dynamic test. Under the C-arm, after you inject the dye, you range the hip out. And if you see that the lateral epiphysis is not going in, and it is still, what is happening is this, then that is called a hinged abduction. That's beautifully seen on an arthrogram, because if it was not to hinge, it would go in when you abduct the hip. But if you abduct the hip and it is sticking there and it is only doing this, then that's called a hinged abduction. That's very well seen on an arthrogram. So that's the two indications where I use arthrogram. I must confess that over the last 20 years or so, my indication for arthrograms have really come down.
Yeah.
I used to do them very frequently before, but I think if you analyze the X-ray well enough and match it with the clinical findings, I think that solves much of the problem. Remember that arthrogram is invasive, so of course it has a role to play, but very limited in today's day and age. MRIs have a good role to play, and especially if you do the latest types of MRIs, which are called the degeneric, where you can actually measure the cartilage because they're gadolinium enhanced. And if you can see the cartilage thickness, then those are again useful in your decision-making process. So there is a role for MRIs, especially centers now which are doing a lot of Perthes work, are putting a lot of stress on degeneric MRIs, where you can actually study the health of the acetabular cartilage, which helps in the decision-making process. But I would say if you look at X-rays well enough and you start analyzing them well, you can fairly come to a good decision-making process, and you can leave MRIs and arthrograms only for those cases where there's really a lot of doubt in your decision-making process.
What about bone scans, sir?
I don't use bone scans at all. I don't think it has much
Nobody
role to play. In the early stages, it will be a cold scan because the head is avascular. So when you have a very early hip condition and you're unable to diagnose it, and you're thinking transient synovitis versus Perthes versus some other condition, then as a sort of a screening tool, a bone scan is helpful because they tell you that if you see a cold scans, it's a sign maybe that you have Perthes as a likely diagnosis. But otherwise, in today's day and age, I think bone scans have a very limited role to play.
I think before MRI, it used to be used a bit more for the diagnosis. Say like someone comes with an irritable hip and you're not sure whether it's going on to a Perthes. So then a bone scan would be done. But today, you probably do an MRI instead.
Yeah.
So, sir, probably.
MRI for looking at containment and what position. If you can't do that because the child can't be moved at that time, I guess. So the arthrogram maybe you can use to look at what position the hip is best contained in.
So you're saying intra during your containment?
No, or even if you do an arthrogram pre-op.
Yeah, sure. But as I've said, we are interested in seeing that lateral epiphysis, and if you see the lateral epiphysis comes within the Perkins line, and especially now we have to understand that we are doing containment surgeries more aggressively. I remember 20 years back, we used to actually wait for extrusion to do containment. But then Benjamin Joseph's paper really changed all of that, because when he showed us in 2003 that if you catch it early in the disease process, there's a 16 times chance of having a Stulberg 1 or 2, then that's really overwhelming evidence to show you that you should do it prophylactically. So if the other parameters, so as I said, don't only look at extrusion, look at the other parameters as well. So that's why the decision-making process is based on those 5 parameters, and I keep reiterating them all the time. You cannot rest on any one parameter to make the decision-making process. There'll be 2 or 3 put together out of those 5 which help you to make the decision-making about Perthes disease. So if you have a little bit of extrusion in a child who's 5, I would still not do containment surgery. I would wait and watch, because we know that just by the age itself, this child has a good prognosis. Whereas if I have an 8-year-old child, even before I see extrusion, but because the child is 8, because it's a girl, because the range of motion is gradually being lost, because I see more than 50% of the head involved, and because I see that's in stage 1A, 1B, or 2A before the extensive fragmentation, I do a prophylactic surgery right there itself. So some people question why call it a containment then? Because the head is already contained. What do you mean by containment? So that's another question that people have, that you can contain something which is extruded. When it's not when it's already contained, what are you containing? All right. So that's a valid question. And it's just a question of semantics, the word that we use. What we're trying to say is that we are improving the position of the head within the acetabulum because we know that potentially it has a chance to extrude, and therefore we are doing it early in the stage of the disease. I think that's one important message that Benjamin Joseph came across and told us, that catching Perthes early in the stage of the disease is crucial to land up with a good result.
What about sort of bracing?
Yeah, so I think bracing in 2020 is outdated. And I'll say that with the chance that a lot of people will object to it, it just does not work practically. Because when you talk of bracing, we have to understand the duration of this disease. So it's important again to understand this, that the stage of avascularity lasts for around 4 to 6 months. The stage of fragmentation lasts for 12 to 18 months. The stage of healing or revascularization lasts for 18 to 24 months. And the heal stage lasts for anything up to even 36 months. So the whole duration of the disease process is about 4 or 5 years. But the crucial period is avascularity and fragmentation. That itself is an 18-month process at the minimum and 2 years at the maximum. So if you want to use bracing as a form of containment, we must be ready to brace that child for a period of 18 months. So using a brace for 3 months or 6 months is not going to be of any use at all. And I defy you to show me a child who is going to use a brace beyond a period of 1 month. So bracing.
What about Perry Shoemaker's work on it?
Yeah, so there's a lot of people, there's a lot of compliance that you have to expect then from parents and from children. And I think in today's day and age, it's so hard to impress upon parents and children to do that. Parents are working, they have no time to sit with their kids at home, children have to go to school. So from the practical point of view, I have not used braces, I think, for the last 20 years now. So if you're taking bracing as a form of treatment, you must be really sure to understand that you're going to brace that child consistently for 12 to 18 months of that child's life. And I think it's not only important to understand the disruption to the child's social life, but also to the psychological effect it has on the child. So I just don't think that method works at all. Theoretically, it's a perfectly good thing to do. Does it work? It works beautifully well if it's followed in the right way, but it is just not practical. And that's why it makes no practical sense to use bracing.
So if you have a child where the parents say, I don't want surgery anyhow.
Yeah.
So is that an option you would give them?
I would still then work on range of motion, physical therapy, intermediate periods of traction, tell the child not to take part in vigorous sports, no contact sports, no jumping, nothing else. I recommend to them that swimming, cycling are two very good exercises because they keep moving the hip. I give them certain exercises that they do in the day where we make the child abduct the hips, several times in the day. I allow them to sit on the ground cross-legged or sit on a chair cross-legged. But I never use bracing because I just don't think it works practically.
What's the role of a Petri or a big neck type of cast? Does it have a role to play?
Petri cast is a very good device to use, as long as we understand what we're using it for. So the Petri cast basically is what we call broomstick plaster, where you give bilateral cylinder cast with a bar in between.
Hip in abduction. Yeah.
So when do we use a Petri cast? The Petri cast is useful when you have a child who is losing hip range of motion. We have a child who is a candidate for containment, but whose hip is so irritable that there's loss of range of motion. So what I do with these children is we put them for bed rest for a period of, as I've said, 7 to 10 days, give them NSAIDs, see if the hip range of motion improves or not. If they a maximum of 3 weeks. So I keep them in hospital for the first 4 or 5 days. Then I send them home and I institute bedside traction. Discontinue the NSAIDs after about 10 days because it's not good giving longer than that. And up to a maximum of 3 weeks. If in 3 weeks' time they come back to me, if the hip is still irritable and the hip is still not having a good range of motion, that's when I take them under anesthesia and they have a definite adduction contracture, because some children do have that. Then I do a small release of the adductors and then put them in a Petri cast so that I get at least interim period between traction and between containment surgery to overcome that soft tissue contracture, to overcome that irritability or the spasm of the adductors, to get them to move well before surgery. Because remember, no osteotomy should be done in a patient who does not have a good hip range of motion. It will never be normal. But as long as you have at least 30 to 40 degrees of abduction and about 45 degrees of internal rotation, you can do your containment surgery. Till then, you should not do any form of osteotomy.
Sir, Sumit want to know.
Hello.
Yeah. Yes, Sumit, ask.
Use of role of weight relieving orthosis, sir.
Weight relieving orthosis.
Yes.
It's kind of.
So as I've said, I don't believe any of those things really work, because we have, when you look at all the different braces, there have been almost 10 different types of braces that have been described, including ischial weight relieving calipers, and then giving a shoe raise on the opposite hip so as to make the other hip go down, the pelvis go down on that hip. But I don't think any of those things really work, So I've given them up. I feel they're all sort of outdated. In today's day and age, they are more theoretical,
impractical,
but they don't work in the social milieu that we live in nowadays. So I discount all forms of calipers and all forms of braces. The only one that I talk of, as John has said, is the Petri cast, and that also a very finite use of it. It's not to be misused. You should not put patients in Petri cast for 3 months because it's worthless. I think not more than 3 weeks, because we have all learned from Salter that, and I think that's the crux in orthopedics. Movement is life, and we must understand that the more we immobilize children, of course, we know that children tolerate immobilization better than adults, but the more you immobilize children for more than a month, you're going to end up with muscle wasting, muscle atrophy, joint stiffness, and all sorts of other problems secondary to plaster disease. So the more we move joints, the better it is.
The hips can be mobilized even with a Petri cast.
With a
Petri cast. It's not with the hip.
You only allow them then flexion extension. That's the only movement that really occurs. But I think the key here is those rotations, because to get that head round, it's that abduction, adduction. It is that rotation which keeps that head round and moving. So I like that hip to be moving all around and not just a planar manner, because flexion extension is not so important as that abduction, and the rotations. So I'm very keen on getting hips moving. I'm very fastidious about checking hip range of motion in children. As I've said, to me, that's a red flag. If I see children losing hip range of motion as I follow them up, that's a red flag for me. And I'm willing to backtrack on my decision to conserve these children and to go ahead with containment surgery earlier rather than later, despite them being younger of age, if I find that the hip is losing range of motion. So I think what's important to understand in Perthes is that we must get our focus off from the x-rays. I feel a lot of times we're treating x-rays in Perthes, and we know that this is one condition where the x-rays look far worse than what the actual condition is. So the stress always here is on symptoms, what the child is actually going through, what's the hip range of motion, and what are we actually treating. We're not treating the x-rays here at all.
So, sir, when child is young, and what advice we should give for activity restriction? What all activity restriction we should advise?
Yeah, so I always tell, when it comes to younger the child, the more you restrict, the better it is, because it's so difficult to restrict younger children. If you tell them restrict 10, they will restrict 5. So it's better to say 20 then, so that they do at least 10. So what I would say is that I tell children who are very young, that tell them they don't do anything at all. Because if you say them don't do anything at all, at least a little bit of running around in the house then becomes acceptable. If you say that if you're running in the house is fine, then they start doing even more than that. So I grade that depending upon the age of the child. Then a little older child who's 7, 8, 9, who's school going, who can understand, I tell them clearly walking is fine. A little bit of running around is okay in the playground. Definitely no jumping exercises. So nothing like, so no jumping is allowed. No contact sport. And rather than saying what not to do, I always say what to do, because it's easier that way then. So I always say swimming, cycling are 2 very good exercises. And a lot of children enjoy that nowadays, So at one time, I remember swimming was a very elite thing that only people who had swimming pools and all could do that. But I have realized that a lot of children have access to swimming pools in their housing complexes, in their local neighborhood. So swimming is a very good exercise that I recommend to children because it's in water. It doesn't cause any weight bearing. It allows a good range of hip motion. It keeps the muscles nice and strong. So I always allow swimming and cycling because they allow the hip to move. I allow squatting and cross leg sitting. But what I don't allow is any contact sport. So I straight away tell them there's no tennis, no squash, no football, no soccer, none of the contact sports where or anything where there's a jumping that's required. So a little bit of running around here and there is perfectly good.
Since when did tennis become a contact sport?
Well, anything. So when I said contact sports, I meant things like soccer and football, of course. But other sports where you have pressure on the hip.
You're playing a different kind of tennis.
Yeah. So anything again. So squash or tennis again, where you have to,
vigorous sports. Let's put it
yeah.
that way.
So where you have to crouch or where you have to go into, a semi squat. I think you should avoid those as well because that puts a lot of load on the hip. So any sport which loads the hip is best avoided. Gentle gymnastics, yoga are all fine. So I have no problems with those things. So I have key message to give.
Just one
And
theoretical.
any experience with the 8 plates and the rationale for it?
In Perthes, no. So I don't see any role for 8 plates here. Um, the role is of trochanteric epiphysiodesis, which has something which is very important, which I always stress about, and that doesn't require an 8 plate. You just have to put a screw across the trochanter. So whenever we are doing a varus osteotomy, or sometimes even at the time of the varus osteotomy, if we forget to do the trochanteric epiphysiodesis, and over time we're seeing that there's a negative articulatrochanteric distance, don't just watch it. It's going to get worse. So at the time of plate removal, if you have wanted to do it at the time of the femoral osteotomy, that is the time when I do a trochanteric epiphysiodesis, that means you drill the trochanter, the lateral half, and you put a screw across it. So that's the only time I do any epiphysiodesis, but otherwise I don't do anything else. There's also some newer concepts about drilling the femoral head, and I think we should also discuss a bit of that because there are some people who talk of that in the very early stages of avascularity, you can also drill the femoral head with multiple drill holes, and there has been some experimental work on that. It hasn't reached a clinical stage yet where we can recommend that, but there are some institutions where they have done some experimental work on multiple drillings for the stage of avascularity. Remember, once the head starts collapsing, it won't work. So this is in the stage 1A or 1B when you have an avascular head where drilling sometimes has a role to play. There are some people who are starting to use bisphosphonates, and there is David Little from Australia, who's a big proponent of the use of bisphosphonates. That's again experimental work. So we know that Harry Kim from US and David Little from Australia are the two big proponents of the use of bisphosphonates. But again, in the early stages. So once you cross the stage of avascularity, these therapies will not work. So if you're considering them, consider them in the early stage. To really pick them up in stage 1A or 1B.
Okay, sir.
Carry on.
Sir, just one theoretical question for exam point of view. When we can call it as a delayed onset Perthes disease? Anything?
Yeah, so late onset Perthes disease is generally when you have an older child who comes with Perthes. And generally, it's when you say older, it's generally more than 10 because you know that Perthes is a disease between the age of 6 to 10. So once you have a child who crosses 10 and who starts developing Perthes at that point, then it's generally a late onset Perthes disease, and that generally has a bad prognosis, especially if it's a girl, because Perthes depends on the amount of time you have for skeletal maturity, for healing to occur. And a girl, develops menarche or puberty much earlier than a boy. So whereas a boy may have at least 4 years of growth remaining at 10, a girl may have just 2 years or maybe just 1 year, and therefore the prognosis is much worse in a girl who develops late onset Perthes. Late onset Perthes is a different entity also because Benjamin has shown it's more immunological. They have more of stiff hips. They have a different disease process entirely. It's not very similar to the Perthes that we talk of, which is in the typical age group of 6 to 10. So the late onset Perthes is a different ballgame altogether. It's more inflammatory. It's more immunological. It generally has a worse prognosis as compared to the typical onset Perthes.
Okay, so any more questions from the students? Otherwise, I think we've given Alaric hard enough time already. So.
No problem. I think this is an important topic that, causes a lot of confusion to people because that decision-making process, which is so crucial, people are not clear about it yet. And if you just base your decisions on X-ray, they're going to land up with a lot of problems. So I think it's good to get a good perspective about what this disease process actually is.
So then maybe we should start asking you about THR and Perthes.
That's something I've never answered at all. I'll leave it to you. Then we tend to leave it over to the adult surgeon, and you can go ahead. But I still say what has changed nowadays in the last 10 years or so with these powerful techniques of hip exploration and the understanding of femoral acetabular impingement, there should not be that need to jump to total hips right away. Though you have a lot of adult surgeons who tell you that we can do it in 16-year-olds. Of course, you can do it in 16-year-olds. The question is, what is the longevity of that hip? You're doing it in a young child, in a young adult who's going to be very active because there's nothing else wrong with that adult. And that longevity of it is going to be about 10, 20 years at the max, you know. So nowadays, when we have these newer trends of hip reconstruction using all the different methods that we have of hip dislocation and osteochondroplasty, that has really delayed the need for total hips now. So anyone who's recommending total hips in a very young adult, I think we should caution them that refer the child instead to a person who does hip reconstructions, because even if you can buy another 10 years more for that hip, that native hip is always better than an artificial hip.
And you can also do relative femoral neck lengthening.
Yes, there are so many procedures.
Yeah.
So whenever you're doing osteochondroplasty, relative neck lengthening goes along with it, because you have to realign the biomechanics of the hip. So it's not only aligning the anatomy, but also the biomechanics. So we also have to then transfer the trochanter lower down. We have to reshape the neck. We have to recreate a longer offset, and you bring the trochanter lower down, because that's a powerful way. Anyhow, you've taken off the trochanter while doing a surgical dislocation. So you set the trochanter a little more laterally and more distally, and that automatically gets lengthening of the femoral neck. That's called a relative neck length.
What about distraction?
Good question. And that's something I have absolutely no experience with, because whenever I've seen any patient with distractions, I've only seen bad results. Of course, there are a group of people who are doing hip distraction routinely and have had good results. And I've always feel that whenever you're doing distraction, I would refer a patient for distraction when there's nothing else that you can do. The hip is really very stiff. There's nothing that I can do as a reconstructive surgeon. That's when we say that, you know, let's try everything that's available with us. And sometimes those very stiff hips, distraction may have a role to play. I personally have very poor experience with it. I sometimes refer it to people who have more experience, and even them, sometimes they don't get good results, because, you know, again, to distract the hip, you have to keep the distraction on for 4 to 6 months for it to have the effect that it has to have. Distracting it for a less amount of time is not very useful. So 3 to 4 months at the minimum, sometimes you go up to 6 months. So it's a long term, and then you have other problems with the hip distraction. So people who are experts with it should be doing it. I personally don't have much say to in this field.
Okay, so thanks, Alaric.
Sure.
Thank you so much, sir.
Great, and I think we should call it a day.
Good, excellent. Thank you so much for inviting me.
Thank you very much for an excellent session, and hopefully catch you again for another one some.
Sure, anytime.
Weeks.
All right. Thank you, guys.
Great. Thanks.
Thank
Bye.
Bye. Thank you.
Bye, Alaric.